صوت. متشكر دكتور هاني حمزة ودكتور تامر مكي على الدعوة، وأرجو أن تكون التوكس مفيدة لحضراتكم. So to provide optimal patient care in ocular oncology, the team of ocular oncology ophthalmologists need to work in close collaboration with other specialties. Like head and neck surgeons, that includes neurosurgeons, ENT specialists, especially for aggressive tumors that may invade the sinuses or into the brain. Also, radiation oncologists, the ocular oncologists should be aware of the potentials and limitations of different types of radiation and decide which one to use, not to just refer it to the radiation oncologist to decide for him. And that's what we're going to go through today. Medical oncology, lots of new drugs are coming that control cancers and are employed in other cancers in the body, and we started to use them for tumors in the eye and around the eye. And you know the advances happening in genetics and pathology that can maybe modify the course of treatment according to the findings. So it's important to have a team of these allied specialties working together with the ocular oncologist. The ocular oncologist could be a group of ophthalmologists from different specialties, but as the service evolves, you start to get ocular oncologists who have the basic skills and knowledge to manage any ophthalmic tumors. You're not required to do orbitotomy and vitrectomy at the same time, but at least you should know the indications as when to use them and to have the skills to do biopsies from any tumor around the eye. Multidisciplinary approach to tumor is becoming standard in most cancers around the world. And in fact, some health authorities mandate that the decision to treat has passed through a multidisciplinary team before the approved treatment. And that's the case in Canada. Like before we say we're going to treat this melanoma, the treatment has to be endorsed by the radiation oncologist, the medical oncologist as well, so that the patient gets the optimal care. The specialty is very well established around the world now, and there are several societies. Most notably, the International Society of Ocular Oncology, they have a biennial meeting, many regional societies, and we look forward to see a representation of Cairo University in these meetings in the future. I'm going to start to talk about management of retinoblastoma. As you all know, retinoblastoma is most common pediatric intraocular cancer. Incidence is about 1 in 15,000 live births. It occurs from mutation of the two alleles of the tumor suppressor gene RB1 on chromosome 13. This is known as Knudsen two-hit hypothesis. It's chromosome 13. You need to have 2 hits to get the suppressor gene function abolished, so the retinoblastoma develops. Leukocoria is the presenting symptoms in more than half of the cases, and it can be apparent for tumors as small as 3 millimeters in the posterior pole. You can start to notice the leukocoria, followed by strabismus and other presentations. By natural selection, the most common form of retinoblastoma is a non-heritable, since 60%. Here, the 2 mutations that we talked about happen in one single progenitor retinal cells, which will evolve into a unilateral unifocal tumor. There is the heritable type, which is, there's no family history, but the germline mutation starts early in the embryogenesis of the proband. This can lead to bilateral and multifocal tumors. And there is the familial type, understood because the chances of procreation here is limited, so it represents only 10% of the cases. The germline mutation comes from the ancestor to the offspring, and as expected, it would be bilateral and multifocal. The problem with the retinoblastoma is that the phenotype does not always represent the genotype. You cannot tell by just examining the patient what is the underlying gene problem happening. So for the facts that we know, according to mutation type, only 20 to 100% of persons with germline mutation will develop RB. Presence of germline mutation doesn't mean that you will develop it. There could be a skip generation. 75% of germline mutations are new in a proband. There is no family history, so you cannot really tell if it's a germline or a sporadic. Unilateral unifocal RB can still be from a germline mutation, is that subsequently you might get the bilaterality, but when the patient is presenting to you with a tumor in one eye, this doesn't rule out that it could be still germline. And germline mutation, as you know, have higher lifetime risk of other cancers like osteosarcoma and melanoma. And there is the problem of mosaicism and incomplete penetrance. So it's really difficult to tell just by examining clinically the patient what is going on at the genetic level. Moreover, there is a subtype of retinoblastoma that happened without RB1 gene mutation, and that was reported by our group. It's a mutation of the MECN oncogene on chromosome 2 that's different from the RB1 gene that we talked about. This shows a retinoblastoma that's sporadic, but it appears at a early age and usually runs an aggressive course. So for that reason, it's important to do tests to check the underlying genetic status in a retinoblastoma case. This is achieved by taking a blood sample and a tumor tissue analysis. So that will help us to identify if there is somatic versus germline gene mutation, the risk of bilaterality in a unilateral RB, identify the type of mutation, detection of mosaicism, and the risk in siblings and offspring. So what are the benefits of that? It modifies the tumor surveillance in a proband. So if you have a child that turned out to be germline mutation, you need to check more frequently the same eye and the other eye. Then it's a unilateral sporadic. You can solve the problem in one step because it's not expected to appear in the other eye. You don't need to subject to so many examinations. Identify relatives in need for surveillance. Prenatal surveillance for at-risk pregnancy, which is detectable by amniocentesis at 16 weeks. And it's more cost efficient if you have a plan for how to follow these cases. There's been revolution in imaging of retinoblastoma in the past 2 to 3 decades. It helps us to put differential diagnosis and do proper follow-up for retinoblastoma cases. So B-scan, for example, detects calcification, measure apical height, can show choroidal invasion, which is a risk factor, optic nerve involvement. Fluorescein angiography can show us the tumor margins, can differentiate tumor versus gliosis. Tumor will have vessels within, gliosis will not. New intrinsic vessels, if you see it growing near to a tumor, could signify tumor recurrence. UBM visualizes the anterior retina and ciliary body involvement in extensive RB, identify ciliary body tumor-free quadrant for intravitreal injections, which is very common nowadays. Before you insert the needle, you need to make sure that there is no tumor in the ciliary body underneath. Anterior extent help for proper staging and treatment planning, and the mechanism of associated glaucoma if present, such as ciliary body rotation, synechia, or angle invasion. OCT show us the earliest budding of retinoblastoma in a newborn. If you're scanning for a newborn with germline mutation, it can appear as a small oval lesion in the middle of the retina. It aids in distinguishing tumor from gliosis. Tumor, as you see, is kind of a small oval lesion. Gliosis usually takes like kind of a flat sheet. And it shows the impact of focal treatment on retinal thickness, especially if you're treating over a calcified tumor. Also, it plays an important role for if there is optic nerve head invasion. So it's a resource-efficient method as compared to MRI to detect the prelaminar optic nerve invasion with retinoblastoma. As you can see here in the picture, this oval lesion appearing on the optic disc, it's growing over time, signifying prelaminar invasion when you cannot clinically detect it because it will all looks like a glistening lesion on the surface of the optic nerve. It's important also to be aware with the updates in grouping and staging of retinoblastoma. This is to speak a common language. This is when I say to the allied cancer specialist, a pediatric oncologist, or I'm talking to referring a patient to my colleagues or reporting the case. It needs to be with the current updated grouping and staging schemes. So in the past, in 1958, Rees Ellsworth put his classification. During that time, the only way to examine the fundus of the eye was the direct ophthalmoscope, and the only available treatment was radiotherapy. So according to that, you find that for him, any lesion anterior to the equator represented a problem because the direct ophthalmoscope cannot trace what's going on at the anterior part. And also vitreous seeding becomes a poor prognosis for the eye because it can stick into the ciliary body or the anterior part of the retina and you cannot see it and can predispose to recurrence. So Rees Ellsworth classification is obsolete nowadays and nobody's using it in reporting. A group of ocular oncologists met in Paris in 2003 and they put forward the International Retinoblastoma classification. This classification came to exist after discovery of chemotherapy as the main line of treatment of retinoblastoma. So that modified the way that we look into tumor and group them. So this classification looks at the potentials for keeping the eye and keeping vision. So group A is the tumors with the best prognosis. These are small tumors away from the optic disc and fovea. Tumors more than 3 millimeter, any location encroaching near the optic nerve and fovea with small subretinal fluid becomes group B. Group C is larger tumor with some fine seeds within 3 millimeters from the tumor because you can contain them with a radioactive plaque or you can contain them with radiation. This represents a group C. Group D, when you have large vitreous and subretinal seeds away from the tumor and there is significant subretinal fluid. And group E, which is usually unsalvageable eye, the disease extended to the anterior segment, there is new vascularization, massive hemorrhage, or the diffuse infiltrating type of retinoblastoma. These are the 5 groups, and it's important to keep them in mind when you come to describe retinoblastoma for the first time. Also, the type of seeds is important because some seeds are easier to control than others. So the dust type, which is like small lesions, small spots near to the main tumor, versus a sphere, which has like kind of small balls, versus a cloud, which is very hard to treat sometimes. Mind you that some of the seeds will appear opaque, some are transparent, and some translucent. So we need to be acquainted with the different kinds of seeds to plan the treatment accordingly. Recently, in 2017, the tumor node metastasis TNM staging, this is the most current classification of the retinoblastoma. It includes both the prognostication for globe salvage, just like the IRBC, and the patient survival. It's the outcome of a large collaborative multi-center retrospective data. And the T here considers tumor size, location within the eye, extraocular extension, and the degree of seeding. So this is all under the T categories, T1, and you find that it's divided into T1A, B, C, and so forth. It combines also clinical and pathologic classification. So if the eye undergoes to inoculation and it shows maybe post-surgical, like beyond surgical margin invasion, the TNM staging changes, and that changes the treatment plan. So how do we treat retinoblastoma? So the initial assessment, when the patient comes for the first time referred, we take family history and we do a pedigree drawing, because as I say, you could have a remote ancestor with history of removing the eye because of a tumor. You should consider that, and you could have a skipped generation. The parents might be normal, but an earlier ancestor have it. Examination under anesthesia with bilateral RETCAM imaging. It's very important to have a RETCAM available so you can have panoramic view of the fundus, and that will help you to detect any small lesion that may appear here or there during the follow-ups. B-scan and UBM are essential, fluorescein angiography at the first visit, because as I say, it will be the baseline if there is a gliosis versus a tumor versus recurrence. And scanning OCT, because sometimes you have very subclinical budding of lesions away from the tumors that you see clinically, and OCT can detect them for you. We take blood samples for gene mutation testing, and if the patient presenting in group E or there is an orbital tumor, we do CSF cytology. We prefer to do MRI rather than CT scan to look if there is a pinealoblastoma associated in case of bilateral lesions, or if it's not available, CT scan of the head and orbit would be essential. And the treatment plan is designed according to the staging. It's important before you start the treatment to rule out the other causes of simulating pathology. You know the long list of causes of leukocoria in the eye. Most two common lesions that can simulate retinoblastoma are astrocytoma, that can simulate endophytic RB, and Coats disease, which can simulate exophytic RB. Exophytic RB from Coats disease, usually Coats disease, the fundus is more yellowish because it's lipid exudation, usually unilateral male, and the course of retinal vessels is that in Coats disease, they stay on the surface within the retina, and they show the corkscrew and the abnormal branching at the periphery, contrary to group D retinoblastoma, where the retinal vessels dip into the tumor to feed the tumor. Having said that, still sometimes it's very, very difficult to differentiate between Coats disease and the retinoblastoma. It's important also to put in mind, in the back of the mind, the possibility of a retinoma. Retinoma occurs as a mutation in the two alleles of RB1 gene, just like the beginning of retinoblastoma. But what happens is that subsequent genomic instability in other genes makes this retinoma progresses into retinoblastoma. And there's been a study by our group here, Helen Damaris. She finds that there is a retinoma at the base of most retinoblastomas, because this is how it started, as a retinoma with more genomic instability. It progresses into a retinoblastoma. However, the progress from retinoma to retinoblastoma may arrest spontaneously, and the lesion will stay there, but you can suspect it by presence of RPE changes at the margin, and the blood vessels around the retinoma are not engorged as in the case of retinoblastoma. So you don't need to over-treat this one. Now, the first line of treatment is systemic chemotherapy, which here is not aimed at curing the lesion, but to reduce the size, downstaging the lesion, called chemoreduction. And that usually is followed by focal therapy. So it's the first line of treatment for bilateral retinoblastoma from group B to D, B, C, D. The use of chemotherapy in group E is debatable. Some groups say, why don't we just go for those advanced retinoblastoma, give chemotherapy and see what might evolve from that. Some studies showed that starting chemotherapy in very advanced retinoblastoma can mask the high metastatic risk. So if there is no vision potential, the patient is in group E, it's recommended to go to inoculation upfront. The three agents that you know is vincristine, etoposide, and carboplatin. They are mostly safe, but like any chemotherapy, they may have toxicity for a child. So it's important to follow a scheme of following those patients down the road. Because of ototoxicity, we do audiography every year for 5 years. For nephrotoxicity, we do renal functions every year for 5 years. Myelodysplasia and AML are remotely reported. We do full blood count per year for 10 years. After the tumor is shrunken in size, we start to do consolidation focal treatments. So we use focal laser, and we can use both wavelength 532 and the diode 810. Usually we use the shorter wavelength to do like a barrage laser around the tumor to cut the blood supply, and the diode laser is directly over the tumor to cover the entire tumor surface. It can be used as the only treatment for group A. You don't need to do any chemo reduction before that, or for small B tumors. The tumor needs to be in a posterior location, so you can reach it with laser with minimal subretinal fluid, so the fluid doesn't act as a heat sink that takes away the heat that you try to induce in the tumor. Cryotherapy will use a triple freeze-thaw technique for peripheral tumors. Usually, once you reach to you see the tumor becomes white in front of you, you count to 5 millimeter and then leave it to thaw, because more destruction happens in thawing than in freezing. So don't accelerate the thawing, leave it to thaw spontaneously, and we repeat 3 times. Would also try to be careful when you're treating a highly calcific tumor, because cryotherapy can cause break in the retina and dispersion of tumor cells, and that becomes a problem down the road. Brachytherapy, we leave it to the end because you're not allowed to use it more than once, because it raises the possibility of radiation retinopathy and other complications. So after the tumor is shrunken and you're left with one unilateral unifocal tumor, we can apply brachytherapy for a tumor more than 3 millimeters that we cannot control by either laser or cryotherapy. And the dose we use is 40 gray to the tumor apex. That's half of what we use for melanoma. Our group recently published our experience with application of iodine 125 plaque radiotherapy for residual or recurrent retinoblastoma. And as you see, it achieves excellent results, like the tumor disappears completely within a short time. Usually the response is much faster than what we see with melanomas. External beam radiotherapy we try to avoid, but we keep it to the end if the chemotherapy failed and the focal therapy failed, and you still have residual massive seeds and multiple tumors coming back, and still the eye you don't want to sacrifice because it has vision potential or the patient lost his other eye. The problem with external beam radiotherapy is that it's not localized only to the tumors. It hits the eye and the orbit. So it raises the risk of secondary cancer in the irradiated area in the germline RB up to 38% at 50 years. Remember, this is a kid that's going to grow over 50 years, so 38% is really a high rate. Also, if you irradiate the orbit before the age of 1 year, you might affect the orbital bone growth, leaving patients with deformities. Inoculation still has a role for any group E tumor. As I said, some people say, let's try chemotherapy, but there is a risk of metastasis here. Or if there is aggressive multiple recurrence with no vision potential, you try to take as long optic nerve stump as possible during the surgery. Now we entered, as you know, the era of regional chemotherapy to avoid the systemic toxicities of systemic chemotherapy. There is the intraarterial chemotherapy, intravitreal chemotherapy, and subtenon's chemotherapy. So intra-arterial chemotherapy is achieved by femoral artery catheterization, and you need good expertise from interventional pediatric radiologist. It can be used as a primary or an adjuvant treatment. Can be applied in 1 session, 2 sessions, up to 5 sessions. Some authorities went to up to 5 sessions. And the agent went from melphalan in the beginning into a combination of melphalan, topotecan, and carboplatin. It is, the secret word here is unilateral. So it can be used as a primary treatment in unilateral group B, C, and D. And in cases of recurrent unilateral multiple tumors or subretinal seeds with vision potentials in one eye. Still, some authorities in New York, they use it as a primary treatment for bilateral, but this, as I will show, has its own complications. This is a technique that has its own complications, which adds to the toxicities of the drug itself. So potential risk if used as a primary treatment for bilateral cases is that increased metastatic risk in advanced cases, because if you have cells that have already leaked into the CSF, or if you have trilateral retinoblastoma, remember that you are treating only the eye and you're not treating the rest of the system. In comparison, when you give a drug that goes through the blood and affect cells in the system. There are specific complications to the technique, which include sectoral choroidal occlusive vasculopathy. You see a big ischemic area in the choroid sometimes after a session of intraarterial chemotherapy, retinal arteriolar embolization and sclerosis, cranial nerve pulses, orbital and eyelid edema. Most of these kids, after the session, you find that they have this area of redness along the distribution of supratrochlear and supraorbital arteries at the forehead. And it's been found that there is a cataractogenic radiation dose from the fluoroscopy that we use during the IAC. So again, it's an excellent treatment for unilateral cases, but don't overuse it. It has its own set of complications in addition to the toxicity of the chemotherapy itself. Sure. دلوقتي؟ طيب بعد السيشن. Second is intravitreal chemotherapy. So we talk here about intravitreal melphalan. It's adjuvant for recurrent and persistent vitreous seeds. So intravitreal is for the vitreous seeds. First, before you do that, you need to rule out seeds mimicking lesions like blood or vitritis or calcifications in the vitreous. You do a UBM at the injection site and search for the seed source. You don't need to inject directly into a tumor. We start by doing AC paracentesis of 0.1 mil, and we aspirate that and give it for cytopathology. Melphalan, we use 20 to 30 microgram, and we aim at the mid-vitreous using a 32 gauge needle. And we do a triple freeze-thaw cryotherapy at the injection site. The results of giving intravitreal chemotherapy improved eye retention by 84% at 2 years in comparison to the cases that had vitreous seeds and did not receive treatment. I have a video here. Let me show it to you, which does not work. So this video shows the technique of intravitreal injection. Oh. الفيديو ظاهر عندي.
مين عندك فكرة؟
How can I make it to work? Okay. So do AC tap, 3.5 millimeter from the limbus. Okay, mid vitreous. And then before the aspiration, we apply the cryo. Before withdrawing the needle, we apply the cryo at the entry site until we make a good ice ball. And then remove the needle and then repeat the cryo again. Okay. Thank you. And the last form of regional chemotherapy is subtenon's chemotherapy. So that was used in the past, like it's not commonly used nowadays. A subtenon injection of 20 milligram of carboplatin can be used as an adjuvant therapy of adjuvant chemotherapy in group C and D. And usually we do cryotherapy, what we call chemocryo, to facilitate entry, like create an inflammation in the scleral wall to facilitate entry of the drug into the eye before we inject in the subtenon's capsule. It has high failure rate as a primary therapy, and that's why, as I say, it's no longer used, and it has its own specific complication that affects ocular motility. It produces orbital fibrosis and fat necrosis, orbital cellulitis, and optic nerve ischemia has been reported. So if the treatment fails and you're going to do inoculation for this eye, it becomes really difficult because everything becomes rigid. Our group is working on an episcleral chemotherapy reservoir, which we call it a chemoplug. It's still under trial, but here instead of putting the carboplatin, just free-floating subtenon, it's contained within a plug, like a reservoir that will stick to the wall of the eye and leave it to diffuse inside the eye over an extended period of time. However, still under trial and the results are not yet published. There are special retinoblastoma cases like orbital retinoblastoma, very advanced. So the group from Brazil found that they represent 18% of their patients. Obviously, in countries with less patient care, primary patient care, they will see more of these cases presenting with orbital involvement. And in these cases, the mortality rate is very high, can reach up to 90%. How it presents? By silent proptosis, in distinction from orbital cellulitis. And you can actually feel a palpable mass around the eye. But obviously, the diagnosis depends on CT scan or MRI. So this protocol of treatment for these cases has been put by a group in India. We use high-dose systemic chemotherapy cycles in the beginning, and we check the patient after cycle number 3. If the orbital component of the lesion has resolved, then we go for inoculation. If the orbital tumor still persists, we go for another 3 cycles. And then we look again after the cycle number 6. If the orbital tumor resolved, then we do the inoculation. If the orbital tumor still persists, then we're left with no option but to do exentration. This is followed by fractionated orbital irradiation for the entire orbit of 50 gray, and you complete 12 cycles of the regular dose chemotherapy. We give high 6 dose, and then we complete with 6 regular dose chemotherapy after that. Because as I say, there is a potential that the tumor has a spread already to the system, and you need chemotherapy for that. Also, the high-risk retinoblastoma, the pathological high-risk retinoblastoma. So after you do enucleation, the pathologist tells you that there is an anterior segment invasion, or there is a choroidal invasion more than 3 millimeter in width, or there is a post-laminar optic nerve invasion, or there is a pre-laminar and any choroidal invasion, or the tumor cells are present at the surgical section, or there is any scleral or extrascleral invasion. All of these represent pathological risk in retinoblastoma. The approach here is to do adjuvant 6 cycles after the enucleation, and 6 monthly CSF cytology for 5 years, and usually harvesting of bone marrow stem cells, because it will be abolished by using the chemotherapy for an extended period of time. So I go here on a summary of the treatment algorithm. These are all the treatments of retinoblastoma. Systemic chemoreduction is the primary treatment in bilateral group B, C, and D. Following cycle number 2, you can start to do your consolidation treatment, because you get the maximum reduction of tumor size after 2 cycles. So you can start right away, do your cryotherapy, laser, or pluck if it's one single unifocal lesion left. However, consolidation focal therapy, laser, cryo, pluck, can be used as a primary treatment in group A. External beam radiotherapy, as we said, we try to avoid, particularly in germline mutation or patients less than 1 year. And we use it in case if everything fails and still the eye has vision potential and you want to keep it because the patient maybe lost his other eye. Enucleation, we go up front in unilateral or bilateral group E, or aggressive or multiple recurrences in group D with no vision potential. Intraarterial chemotherapy is the primary treatment in unilateral group B, C, and D, or recurrent unilateral multiple tumors, subretinal seeds with vision potential. Intravitreal for the seeds, so it's for primary, residual, or recurrent vitreous seeds in group C and D. And subtenon chemotherapy, as we say, carboplatin is rarely used nowadays, and we are in the process of developing chemoplaque as a reservoir for chemotherapy. Thank you.
طبعا في حاجات انا عارفها حاجات خطر ابتدائي اللي هي بالنسبه للرول ايوه، وفي ناس بتعملها كمان في الفايلنت تركيز صحيح. يعني هو بيقول لك ما دام اوريدي هي ديد الكاثيترايزيشن بتاع الاوفثالميك ارتري فهي كان جو ان ذا اذر ارتري از ويل ودول. فايه رايك في الابروتش دوت؟
As I say, like, it's controversial. So David Abramson, who's like kind of the promoter of, he uses it in place of systemic chemotherapy. The argument against is that this is a regional chemotherapy. So if you have cells outside the eye in the CSF, or if it is pineoblastoma, you miss those. So, and the toxicity of systemic chemotherapy is not long lasting. It's just during the course of the systemic chemotherapy. You give the 3 cycles, 6 cycles, and then the child comes back to normal. So why to take the risk? Again, it depends on the interventional radiologist you're working with. Is he so good, so efficient that he wouldn't cause the complications of the technique itself? Or there is a question that because administration of systemic chemotherapy is straightforward, not a big deal, but the other one requires a skill. So it depends really on who you're working with, and the potential of having cells outside the eyes in advanced cases that you might miss and can predispose to metastasis.
هو في الستادي اللي كانت اتعملت في الاول فعلا الحالات اللي خدت انترا ارتيريال كان في 2 cases developed systemic metastasis despite the local control. انما بالتالي بالبروبر ايميجينج this can be detected early. يعني دي حاجه. يعني الحاجه الثانيه اللي عايز اسالك فيها، طب انت النهارده عملت systemic chemotherapy after 3 cycles you don't have enough local response. Would you augment the intra-arterial
Yes,
as well?
it can be used as adjuvant treatment. That's what I
As
mentioned.
adjuvant treatment
Yeah.
as well.
Yeah.
during السيستميك كيموثيرابي. يعني هو خد 3 سايكلز او 4 سايكلز وانت مش شايف لوكال ريسبونس
No, I switch.
you switch بقى.
Yeah, switch.
هتستوب السيستميك
Systemic. It's
مش
not
كده؟
working. There's
and
no
you
way to
switch
turn.
to
Yeah.
intra-arterial. يعني دي
Yes.
برضو نقطة كانت controversial بيننا وبين اللي هم
No, switch. There's no point in to carry on a road that it's blocked.
بالظبط.
Yeah.
بالظبط. نقطة تانية برضو أحب بالنسبة للديفرنشال دايجنوزز، الحقيقة أنا شايف كوتس ديزيز هو أكتر حاجة بتلخبط ستيج 5 بالذات بتاعته، اللي هو تلاقي توتال اكسوداتيف ديتاتشمنت وأنت مش عارف إيه اللي ورا، مش شايف الابنورمال فيسلز بتاعت الكوتس اللي هي الكلاب شيب فيسلز والدايليتد، لأن الريتنا ورا اللينس في الحالتين. فهل عندك اني سبيشال كلوز للحالات دي؟ الحالات دي ساعات بايوبسي، هتاخد بايوبسي من السب ريتنا فلويد بقى.
السبريتنا فلويد، يس.
مش كده؟
يس.
هتاخد سامبل من السب
بنفس التكنيك اللي احنا بنعمل بيه الانترافيترال that you do cryotherapy as you withdraw the needle.
بس خلي بالك ده الريتنا ورا اللينس، يعني you have to go from
Yes.
behind to get the sample.
Yes,
يعني
yes.
هتفتح وتخش من عند الاكويتور بنيدل and you withdraw
Correct.
السب ريتنا فلويد. ده الاونلي تكنيك اللي ممكن نعمله. هي فعلا انا كان في مره حاله كده، يعني كل الستادي كل الايمجنج واتعاد كذا مره كان مطلعها كوتس، بس وانا بشتغل اخدت سامبل من السب ريتنا فلويد اند بروف تو بي ريتينوبلاستوما ذات تايم. ده من 10 سنين الكلام ده.
خصوصا ان ممكن الكوتس ديزيز يبقى معاه كالسيفيكيشن. او ممكن ريتينوبلاستوما وذات كالسيفيكيشن. ده كان
وده وارد. فده الاوفرلاب هنا بيبقى الحقيقه صعب جدا في بعض الحالات، يعني مش كلهم. حاجه ثانيه الفيتريس سيدز. طيب فيتريس سيدز احنا كلنا عارفين الفيتريس سيدز الريسبونس تو تريتمنت لما بتبقى كالسيفايد يعني وايتش ان كلر يبقى فيه جود ريسبونس، بس sometimes we are not that confident بالنسبه لنا. برضو any special additional clues for
once you suspect treat
only on the basis of suspicion. ما هي ده اللي بيحصل.
once you suspect clinically treat it's better than missing that there are active seeds there and you postpone treatment for a month or two and it becomes out of control.
Okay. طيب
and let me add something. Usually the area that's missed is the area around the ciliary body. Like and the only way to visualize this is to do UBMs. Proper UBMs.
ودي يمكن احنا محتاجين نضيفها عندنا ان احنا نعمل UBM اكتر من كده لحالات الريتينوبلاستوما. دي ما عندنا الUBM
very important. As I told you, that changed the Reese Ellsworth into the new classification because the anterior part was always missed and that's where the recurrence always happens. So UBMs is important.
طيب في الانترا ارتيريال بقى هل بتبدا بالملفلان اونلي ولا كومبينيشن تريتمنت ملفلان توبوتيكان؟
Nowadays it's the combination.
الفري دراجز الدوز بتاعت الكاربوبلاتين في الانترا ارتيريال قد ايه عشان نجايد
I cannot remember but it's usually prepared by the medical oncologist. I can get it to you.
تمام. حاجه ثانيه انا عمال اكتب الحاجات البوينتس اوف كونتروفيرسي. الدوز اوف راديشن في الريتينوبلاستوما انتوا بتدوا 40 جرام. في اسن في المانيا لقوا ان اللو دوز الريكارنس ريت فيها اعلى فابتدوا يدي 90 جرام ليهم. and they showed ان هي
احنا بنتكلم على البلاكس.
على البلاكس. فلقوا ان هو الريجريشن ريت احسن عندهم.
مع احترامي لالمانيا الاستادي اللي انا نشرتها من اور جروب we always use 40 جراي بس في precautions بنعملها.
بتستعملوا روثينيوم ولا ايودين؟
بنستخدم ايودين. انا I'll come to that. ال 40 جراي لما بتيجي تعمل بلاننج بيختلف شويه عن البلاننج بتاع الميلانوما. We add extra 1 millimeter over the ultrasound height because this is a retinal tumor, not a choroidal tumor. So we add the choroidal thickness. And also we take into account the fast growth of of the tumor in retinoblastoma. So if I have a gap between diagnosis and the treatment of a couple of weeks, I add extra 1 millimeter. Also, I add to the seeds at the surface of the tumor. If I have fine seeds, I include those in the radiation here. So the 40 gray should even cover the seeds.
يبقى definitely الايبكس هياخد اكتر من 40 جرام.
بالظبط.
That's the same.
But we always stuck to 40 gray. That was the recommendation of the brachytherapy group. I think I sent you the guidelines for what to use in melanoma, what to use in retinoblastoma. So, and we achieved excellent results if you read the paper.
كده ايه؟
cases presenting with bilateral disease. So we go with upfront inoculation, bilateral inoculation.
That's a controversial point, as I say. Like some authorities said that if you don't go upfront to inoculation, you promote the possibility of systemic metastasis. If you try to attempt chemotherapy, because chemotherapy doesn't work instantly. It's a cumulative thing. So if you give it a chance of 2 cycles, 3 cycles before it starts to show its effect, and you have seeds in the system, you give it a chance to metastasize. Some people say maybe one of the eye would shrink and you still keep one eye of them, one of the two. Why don't we give systemic why don't we do systemic chemotherapy first, especially if something like we can keep the eye subsequently. So like we have seen few cases of bilateral group E. This presentation is quite rare, but from what I saw, I think we went to upfront inoculation both eyes.
ده هنا بنشوفهم مش قليل.
What do you do?
It's very tough الحقيقه انك انت مثلا تتكلم مع الاهل ان هو بايلاترال. احنا our يعني policy ان احنا we try to salvage one eye.
Of course.
يعني انه تقول له ان احنا we are going to remove both eyes of your child، دي حاجه يعني انا شايف انها بالرغم ان هم الاوكيلر اونكولوجيست اللي هم الانكولوجي بتوع الكيموثيرابي يقول لك اعمل انفليشن. ما اعرفش هم يعني زي اقول لهم طب we try in one eye even، يعني نشوف المور ادفانسد فيهم وتتشال والثانيه we try. بس
did you try high dose chemotherapy cycles like the BEC high dose?
لا we did not try. لازم نتكلم معاهم فيها يمكن.
Yeah,
هم بتوع
maybe it's worth.
اه
As I say, like I encountered 1 or 2 cases maybe, and we went straight to inoculation both eyes.
both eyes.
6 cycles. يعني ما عنديش خبره جامده في البايلاترال جروب.
يعني احنا بنواجهها هنا بس بنحاول نكمبرومايز شويه فيها ونشوف لو هي مش ريسبونسيف للسيستميك كيمو خلاص we proceed with inoculation. That's the only option. لسه
يس في الفيرست فيزيت، لانه زي ما قلت بيديلينيت الادجز اوف tumors especially the flat ones والpart that's gliosis from vascular that's active, and you have it as a baseline. So if there is a recurrence and new vessels are growing in one area, it could be like just like a sheet of cells with front of blood vessels that tells you that the recurrence is happening. And the only way to visualize that is with fluorescein angiogram.
ده ينفع لغايه جروب بي اور سي ماكسيمم، يعني بعد كده ما تقدرش تعمل.
يس.
ما يبينش حاجه.
Yeah.
والاو سي تي برضه روتين في جروب اي اند بي عندهم. ولا when you suspect.
And C, and in particular patients that of the heritable type, like the possibility of bilateralism. So you need to scan because there could be small buds that you cannot see clinically. They are translucent, very small. So once you pick them, you start to treat them right away.
So you go in the better eye ممكن اللي هي لسه ما
in the better eye, yes.
And
you scan all the posterior pole as possible.
Another important point.
Do you have what kind of OCT you have for it?
عندنا البورتبل او سي تي
اللي هو البايوبتيجن اوبتوبيول.
المفروض ان هو برضه كويس
يعني.
بس you can rotate the eye and scan under anesthesia and try to go as peripheral as possible.
But they also don't use it as scan. So the protocol, how frequent you do this follow-up, and also the follow-up while the child is on systemic chemotherapy. We follow up the child after each cycle?
Yes.
After each cycle.
No, just before each cycle.
Okay.
Like you give the cycle and leave it to work,
Stand
and
to
before
work.
you give the second cycle, you check the cycle. So you decide about what are the next steps.
And once there is no response, خلاص, you stop systemic chemo even after the second or third cycle, and you shift to intra-arterial.
Because you use different set of chemotherapy that they work at a different level of the cell cycle. So if these are not working, what's the
We
point?
can add بقى كاربوبلاتين كمان للانترا-arterial. نبقى نشوف الدوز بتاعها. اسأل معايا.
If you don't do another round of brachytherapy, you any clinical scenario other than look like another round of brachytherapy if the first down.
You can always do as many brachytherapy, بس كل مرة أنت increase the rate of radiation retinopathy. Like you're trying to save, but you blind the eye by a different mechanism, and you get the patient into more complication. And once you get into radiation retinopathy, the control of retinoblastoma becomes more complex. So you leave it to the end. Don't overuse. Yes, like this study that we made is just only 18 patients and we are a major center. So we leave it to the end. That's why we call it recurrent or residual retinoblastoma. But we try not to avoid it as a primary treatment. You give the maximum chance to chemo reduction, try to use the other kind of focal consolidation, and leave the brachytherapy to the end.
I think it depends on the size of the residual tumor after.
Exactly, like it's more than 3 millimeter, it's unifocal, you use
than
it.
we have.
Yeah.
Yes, is that better?
Yes, intravitreal chemo is more effective. زي ما شفت 3 types of seeds, the tiny one, the dusty one, the spheres. Usually the intravitreal works very well with those. Cloudy one might be a little bit resistant. And in that case, if the cloud is within the apex of a tumor, we use plaque radiotherapy. We include that, like we include it in the height. If it's a diffuse and multifocal clouds, then we use external beam radiotherapy. External beam radiotherapy is very effective in seeds, more than the intravitreal injection, but again, because of its side effects, we leave it to the end. Yes. Because there's not much blood supply to the vitruses,
Ali.
How long would you follow up with retinoblastoma or the 2 cycles? How frequent is the follow-up?
So once you suspect it, you follow it frequently, like every month, every 2 months in the beginning. And if you see no changes happening, you start to increase between the visits, make it every 3 months, 6 months, still no changes, then you comfortable that it's nothing that's gonna grow. The possibility of retinoma switching to a retinoblastoma even in adults is about 4%. So you don't lose track of those. Like as I say, we've seen cases of adult retinoblastoma. They had retinoma since childhood, and it switched at the age of 30 years. So you at least give a 1-year follow-up for those patients. Lifelong, yeah.
And is there any intervention that you recommend after clinic?
No.
Ali.
Any treatment has its own complications, so you don't try not to treat unnecessarily.
مش شغال. ملوش لازمة.
Yes, we use it. If you see 1 or 2 seeds in the anterior segment, theoretically it's group E now, and we should not do anything. But if you see 1 or 2 cycles and the eye has an anterior tumor and still has vision potential, so we treat them. We treat the main tumor and also we give injection intracameral for the couple of seeds. Yes, but any scenario can happen. You can have an anterior tumor, posterior pole is clear, and you have a couple of seeds in the anterior chamber, so you can give intracameral.
في انت قلت برضه نقطه مهمه في الكرايوثيرابي في الكالسيفيك تيومر. الحقيقه الحالات دي انا شفت منها بعدها بيجي ساعات ديتاتشمنت، ديجماتوجينس ديتاتشمنت، بيجي لهم بريكس اند اي هاف تو اوبريت اون 1 اور 2 كيسز بالمنظر ده من الكرايوثيرابي والتراكشن على الاتش بتاع التيومر يعني. بس غير كده الحقيقه يعني محاضره جميله يعني. We can proceed to the next talk.